Hi. Well, I'd like to introduce myself. I'm Harmony Frederick. I'm a GNE patient, and I'm very excited to be able to introduce our speaker today. We have Denise Davis with us. She's a physical therapist who earned a Bachelor of Science degree in Kinesiology from California State Polytechnic University in Pomona. And she has her master's degree from physical therapy from California State University, Long Beach. She began her career at UCI Medical Center in 2004 in the acute setting and has gained experience working in the Acute Rehabilitation Unit, Outpatient Unit, Wound Clinic, and Lymphedema Clinic. Currently, Denise primarily works in the Outpatient Physical Therapy Clinic at UCI, where she treats orthopedic, lymphedemic, and neurologically involved patients. Denise became involved in research with the Neuromuscular Clinic in 2008 and continues to be an active clinical investigator for several research studies for rare neuromuscular diseases. She serves as a primary physical therapist for the GNE Myopathy Clinic and the secondary physical therapist for ALS and Myasthenia Gravis Clinic. So she's going to give us a great presentation today. As she presents, please feel free to ask any questions, put them in the Q&A, and we'll go ahead and address those at the end of the session. So I'm going to turn it over to Denise, and we'll go from there. Thanks, Denise.
Thanks, Harmony. So I am the primary therapist at the GNE Myopathy Clinic at UCI. So I thought I'd discuss kind of the things that we talk about with patients when they come to visit us, to give patients who are going to come an idea of what we're going to talk about, and they can prepare questions. And for those who can't make it to see us, give you an idea of what we talk about and how we can help patients. So some of the most common questions patients come up with are, what exercises are the best for me to do? What exercises should I avoid and shouldn't I do that can damage some of the muscles that I have? And when should I start using assistive devices or AFOs? And all these questions are really trying to focus on maintaining your function for as long as possible and maintaining your ability to walk and to ambulate and to perform transfers in a safe manner. So when you come visit us at UCI, this is my shameless plug for UCI. You'll first see the physicians and the fellows who will confirm your diagnosis and then also work on medical management of your GNE myopathy. Then you'll see the physical therapist, usually myself, and we'll talk about your functional mobility, how you're managing your day-to-day activities, your home environment, your work environment. You'll also see an occupational therapist who will talk about your activities of daily living, hand function, hand weakness. You'll see a genetic counselor, a social worker who can provide you with community resources, and then our nurse coordinator who kind of coordinates your your visit, keeping all the pieces moving, and our medical assistants who will take your vitals and draw labs. So when you come and you'll see the physical therapist, usually myself, we'll talk about your current level of mobility, what assistive devices you're currently using, and how you're managing your day-to-day. We'll talk about your work environment, your home environment. I'll take a look at your walking, and then we'll kind of develop an exercise and a stretching program for you to start doing with the goals of maintaining your independence with functional mobility for as long as possible. So home safety. Some of the tips that we talk about are removing clutter from your walkways, trying to, if you have little kids with small toys, really trying to keep those toys away from the aisles and away from the walkways, keeping them clear to decrease your chances of tripping. Removing area rugs, because when you change the level of the surfaces, you have a higher risk of tripping because of drop foot, because of the toes hanging down and being able to catch on certain surfaces. So really trying to maintain one level throughout your entire home. So removing area rugs, usually along hallways or in front of sinks or in the bathrooms, those can be a little bit of a fall risk. So I usually have patients remove those. Bathroom modifications. If you have the ability to, oh my goodness, excuse me, I'm so sorry. Sorry, troubles from working from home. bathroom modifications, being able to, if you are able to modify your bathroom, to have a walk-in shower built, using the shower chair and with a handheld shower. That way you can sit, you can rinse and clean without having to use as much energy while standing, also decreasing your fall risk while in the bathroom. Grab bars in the showers and around the toilet are also great ideas. Raised toilet seats to help you to be able to sit to stand to help save some energy. Also, there's sit to stand devices to help you raising the level of the surfaces. So if you're going to like a restaurant or to a friend's home, some people just kind of bring large cushions to sit on to make standing up a little bit easier. Wearing proper footwear. So trying to avoid slippers or flip-flops or things that aren't secured to your foot. So can increase your risk of falling. So really trying to wear something like tennis shoes or a sneaker or something that fits a little more snugly on your foot. Energy conservation. So as the disease progresses and weakness continues, really trying to save energy in areas where you can. So I like to think of it as you have one tank of gas, and how are you going to use that throughout the entire day? So you kind of want to use it for things that you feel are most important for you to do and things that you enjoy. So if dressing takes you an hour to do in the morning, and you're tired for hours after that, maybe having somebody help you with dressing. Also breaking things into smaller tasks. So if you're thinking about cleaning the bathroom, maybe clean the mirrors first and then take a little break, and then do the countertops and take a little break, and then clean the floors, and try not to do all these things at one time. So that way you're not tired for the rest of the day. Showering takes a lot of energy, and in the bathroom, because they're so small and when the surfaces are wet, it creates a little bit of a fall risk. So trying to shower or bathe when you feel like you have the most energy. So some people like to shower in the morning when they feel like they have the most energy. And then others like to shower in the evening. That way they can shower, they can have assistants, they can have their caretakers or their families help them with that, and then they're so tired from the shower that they just go straight to bed. So trying to figure out what works best for you with your family and with your caretakers. So then we'll take a look at your gait. So we'll have you stand up, see how you're sitting, do a sit to stand, walk down the hallway, turn, and come back. And some of the biggest things that I recommend with the walking and the turning are when you turn, just maintaining your a wide base of support. So keeping your feet apart as you turn rather than crossing one over the other, or if you're going to change directions, keep your feet apart. That way, because when you cross your legs, you're making a smaller base of support, and that can lead to a little bit of imbalance or a fall. So keep feet apart when you turn. We'll also make recommendations on assistive devices. So these are the most common things that we recommend are AFOs, walkers, wheelchairs, and then we'll talk about AFOs next. So ankle foot orthoses, usually to help control drop foot, right? Because as you're walking, your foot kind of hangs down. You don't have the ability to lift your foot, to clear your toes. And so things patients do to compensate are they'll use a steppage gait where you lift your hip higher to clear your foot. And so if you think about it, with each step you're having to lift higher than usual, it requires a lot more energy, and it can be overtaxing on your hip flexors. So using an AFO, I usually recommend carbon fiber because they're lightweight and they're durable. And then an anterior. They have anterior and posterior AFOs, usually the anterior because quads remain strong. So I usually have them, most patients usually find the anterior AFOs a little bit more comfortable to wear. Walkers. As hip weakness progresses, walkers are a great way to maintain your mobility and stay safe. I usually recommend a four-wheeled walker with a seat. That way patients can walk for a distance, and then when they feel like they're getting a little tired, they can sit down, take a break, and then you can stand up and walk again when you're ready. They'll help keep your body more in midline, because as your hips get a little weaker, your body will kind of lean to the side, and then you step and then lean to the other side. And so that side to side motion of your trunk can lead to some lower back pain. And using the walker to help steady with your hands will help keep your body a little bit more in midline. So you're conserving energy. You might be able to walk a little further before getting tired, and helps improve your safety. Wheelchairs. So wheelchairs is always a tough conversation to have. I usually recommend patients start with a transport wheelchair, which is that wheelchair on the top here, because it has the smaller casters. You don't need the big heavy wheels on the sides, because you're not going to be pushing the wheelchair. Somebody's going to be usually helping you push to manage community distances. So using a transport wheelchair when you're going to be going out for a longer time. And then when you feel ready, moving into a power wheelchair. So I recommend going to a physical therapy seating center when you're ready, because each piece of the wheelchair needs to be medically justified. So you'll need to justify the armrest, the leg rest, your seat cushion, how you're going to control the wheelchair with what type of joystick or head control, or having one put in the back so that caretakers can control your wheelchair. Those all need to be justified. So going to a seating center where somebody can help you manage those things. And wheelchairs take about 3 to 6 months to fabricate. So just plan ahead and plan accordingly. I recommend patients usually get the tilt in space feature. That way, instead of just being able to recline the back, the whole seat will recline with you. So the whole bottom of the seat and the back come together to allow pressure relief off of your sacrum and off of your lower legs. Insurance usually covers wheelchairs every 5 years, so just keep that in mind. I'll have patients usually purchase the transport wheelchair because it only costs, not only, but it costs about $100, $125, whereas a manual power wheelchair would cost $10,000 to $20,000, depending on your features. I don't usually recommend scooters because they have a little bit tendency more to tip over on unlevel surfaces. And then most scooters are controlled with a handlebar and either hand or thumb functions. And with arm weakness and hand weaknesses, sometimes those aren't as practical as just moving straight into a power wheelchair when ready. So what are some of the best exercises to do? I always tell patients that the best exercises to do are something that you enjoy and something that you'll continue to do, right? Exercises shouldn't feel like they're punishment, or they shouldn't feel tedious. It should be something that you like to do. So I like to do exercises usually that have a little bit of aerobic component and also have some type of resistance component as well. So swimming or water aerobics, a seated bike or seated elliptical are great. Yoga, Pilates. You can also do yoga and Pilates with in a chair. There's great community resources usually at your community centers that have exercise classes for discounted prices. You can also just download, some of these, some classes or some videos off of the internet. There's a lot of resources, so you can look. You can also just do some meditating or some breathing classes or stretches. Those are also good for maintaining your joint range of motion and helps with relaxation techniques. Exercises to avoid. So things that you shouldn't do are really high intensity workouts, things like CrossFit, that you're doing a lot of jumping, a lot of eccentric loading, because those really strain the muscles a little bit more. No heavy weightlifting, because you really want to prevent over fatigue of those muscles. And you shouldn't have any pain with your exercises or your stretches. So some of the precautions with doing exercises. So it's usually okay to strengthen anti-gravity muscles 3 times a week. So you want to alternate your days. So you'll strengthen or do exercises one day, and then you'll have a day of rest and recovery. And then you'll do exercises the next day, and then have another day to rest and recover. And you really, to avoid overfatigue while you're exercising, and then allow your body to recover for a day. So you shouldn't really have any muscle soreness after exercises. And you don't want to exercise to the point that you're not able to do the things that you normally can. So if you exercise and then an hour later you're having a little bit more difficulty walking, or you're having more difficulty getting out of a chair, you know you've done a little bit too much during that session, and you'll need to kind of back off a little bit, because the ability to rebuild the muscle just isn't as capable as it was before. So really trying to avoid over fatigue. And unfortunately, there's no real straightforward answer to how much is enough and how much isn't enough. You kind of just have to use a little bit of trial and error of trying maybe 2 sets of maybe 5 or 6 exercises, and then wait and see how you feel that later that day. And if you feel okay, maybe the next time you do the exercises, you can add a couple more repetitions. But if you feel like you're getting weaker after you do these exercises, you might need to back off. And so some of the muscle weakness patterns with GNE myopathy, the muscles on the left here are usually stronger than the muscles on the right. So the muscles on the left, you can work a little bit more against gravity, whereas these muscles on the right, the hamstrings, the hip adductors, your hip flexors, and your finger flexors, you might want to work just isometric exercises or stretches, depending on your level of strength. Some of the questions fielded to me before this, while I was putting together this presentation, were what exercises can I do independently by myself without any help? So I kind of categorize these into 2 groups, for patients who are ambulatory and then patients who are non-ambulatory. So for the ambulatory group, just some simple basic exercises are great. Sit to stands, standing heel raises, lunges, either forward, side, back, any type of balance exercise to really keep the coordination and the proprioception in your feet and your legs to help you with your balance and to maintain your safety. And when you're thinking about doing these exercises, you don't have to do a full range. You can modify it to what you can do safely and comfortably. Exercises for patients who are non-ambulatory. Think about doing isometric exercises. So just think about contracting the muscles, turning them on. So for like the hip adductors are usually weak in patients. So think about just squeezing your legs together, holding for a few seconds, and then relaxing. And then again, squeezing, holding for a few seconds, and then relaxing. You can also do hip abduction, so pushing your legs apart, seated knee extensions where you're kind of kicking a little forward, ankle pumps, just even lifting your heels just a little bit and coming down, toe curls, and then also finger gripping exercises, finger opposition. You can do finger stretches either on your hands, your forearms, or on your legs to help maintain finger extension and just stretching. Excuse me. I manage neck weakness. Unfortunately, there's not a cervical collar out there that I know that is meant to hold the weight of your neck. Most collars are made for immobility, to stabilize, like after you get into a car accident or after you've had neck surgery. They're meant to stabilize and immobilize your neck in one position. They're not really made to hold the weight of your head. So a lot of patients who wear neck collars, cervical collars, get neck soreness right along their chin from the weight of their head just resting on their chin, usually about after 20 to 30 minutes. So I usually just recommend a soft collar, like these first top 2 pictures, to wear mostly during transfers. So if you're going to do a sit to stand and you have some head drop, wearing the collar so that way it holds your head into a more neutral position while you're coming forward to be able to stand up. Also wearing it when you're eating to keep your head up. so that you facilitate your swallow and you're not aspirating. Or while you're driving, especially in a car, to manage turns, to go over speed bumps, you really want a neck collar on, a cervical collar on to help support your head. If you are looking for a more firm or rigid cervical collar, I recommend this Headmaster, which is the picture on the bottom down here. It comes from your sternum and your chin, so same thing, your head, the weight of your head is resting on your chin. And they come in different sizes, so depending on the length of your chin and also the length of your neck, they'll fit one to you. But this is probably the most comfortable firm collar that I've seen out there. But if you know of one, please reach out to me. I'd love to learn about it and be able to pass that information along to others. Also, just sitting, if you're going to be sitting, like look for a chair that has a high back or one that's against the wall so you can recline and then lean your head back to keep in more upright position. Some other questions are, what is the best way for me to get in and out of bed? This is a tough one. Obviously, log rolling is the best way to do it. Bending knees, rolling your whole body onto your side and then pushing up. But as your triceps get weaker, pushing up is difficult. Bending knees with hip flexor weakness is difficult. So sometimes using a bed rail or a pole where you can kind of hook your biceps and pull yourself up a little bit. An adjustable bed is a great option because that way you can just raise the bed all the way up. Swing legs out and then kind of pivot to get out of bed that way. Or just really needing somebody to help you manage your legs and trunk when getting in and out of bed. Sleeping position recommendations. This is also another difficult question. Using lots of pillows, right? Support when you're on your sideline, pillow between your neck and your shoulder to support your head. Also between your knees when you're on your sides. One pillow between your body and your arm to kind of keep your arm a little bit away from your body to give your shoulder some in a more neutral position. When you're on your back, I like to put the pillows behind your neck and then kind of pull the corners of the pillow over your neck, over your shoulders to kind of cradle your neck and give you a little support that way. That really, it comes down to changing positions every 2 to 3 hours, which can be difficult. So either using bed rails or a pole or something to kind of turn, or having somebody come in or waking your partner up and having them help you reposition every 2 or 3 hours. How to prevent pressure sores. So honestly, I haven't seen a lot of GNE myopathy patients with pressure sores. Usually pressure sores are caused in patient populations where they don't have great sensation. Or they don't have the cognitive ability or the ability to communicate that they're in pain, or they're having a pain over specific areas. Most patients with GNE myopathy are able to communicate and their cognition is intact. So I don't really see this a lot. But if you are having some trouble, same thing, offloading, repositioning every 2 to 3 hours, making sure if you're in a wheelchair that and it's inflated properly. And then protecting your bony landmarks, right? Extra padding over your ITs where you sit, over your hip, your greater trochanter, sometimes over ankle and heels, making sure those are floating if you're going to be in bed. Same thing with elbows. Use lots of pillows for support. And how to manage swollen feet in wheelchair users. When you're sitting, gravity kind of pulls all this fluid down into your feet and into your ankles. And how do you combat that? So usually I have patients wear compression stockings, 20 to 30 milligrams of mercury, usually about a knee-high stocking sock that you can buy just over the counter on Amazon. They have everything. And then you just take a measurement of your ankle and your calf and you can kind of fit yourself that way. And put these on when you're going to be sitting. So if you're going to be transferring from your bed into the wheelchair, put them on right before you transfer. Put on shoes that are lace up, maybe that you can put on snugly so it helps contain your fluid so it doesn't swell too much. Also, while you're sitting, you can also elevate your legs or do a little bit of a heel raise if you're able to help contract the calf muscles to pump to help move fluid up and out of your legs. You can also have your caretakers or your family do a little massaging, retrograde massaging to your feet and to your ankles once you transfer back into the bed. So the key takeaway points for here, just keep moving, keep being as active for as long as you can, doing your normal daily activities. Sometimes you get to the point where just doing your activities of daily living is your exercise. And so we say just let life be your exercise. But if you're stronger, then you can do mild intensity exercises 3 times a week, alternating days of exercise and a day for rest, and then use assistive devices, right, to maintain your safety and to prevent over fatigue and compensations in other muscles. Thank you so much for having me. Were there any questions from the audience? Let me see if I can stop sharing here.
That was very helpful.
Thank you.
We haven't got any questions yet, but if anybody that's watching has any questions, please put that in the question and answer section there. I do have a question myself. You mentioned about the neck weakness, and I've noticed recently myself I have in the car, it's just something that you mentioned too, is that, you know, you kind of get jostled around and a little bit of pain. And I'm noticing I'm in more pain after I get out of going somewhere in the car. So would wearing a neck brace, it sounds like that might be the best solution, or do you have any other advice about kind of helping with that situation?
Right, I would definitely get a soft cervical collar to wear while in the car, just to give your neck some support while you're driving, to manage the turns, and speed bumps are usually the worst.
Yeah, so. Okay. Awesome, thank you. Okay, we do have a couple of questions that have come in. So the first one is a compactor or massage daily use good? A massager, sorry. So it's like a daily massage. Is it good to use daily, a massager or a compactor?
You can use a massager daily. There's no harm in that. As long as it's not painful, or you're not, as long as it's not painful, you can use a massager.
Okay, great.
And making sure your skin is intact too.
Okay, so sorry, what was that? Making sure?
Oh, just that your skin isn't like breaking down, or you're not getting any like redness or skin irritation from this massager. You can continue to use it daily.
Okay. Great. Another question came in. What are some good shoulder exercises for us?
Shoulder. So if you can lift against gravity, doing any type of reaching exercises, reaching up to the side, across your body, or you can do like rowing or lat pull downs, either with a resistance band or with free weights. And then just using your arms to kind of help you stand up. You can just push down like onto your hand rests, arm rests, to do little triceps and to do lat work.
Okay. Another question we have is cold in winter. Let's see, dimensional to GNE patients. Is it a good idea to move to warm climates? So I guess the question is more about if you're living somewhere where it's colder, is that a concern for us GNE patients? Would it be better to move somewhere where it's warmer?
That's a tough one. I think you can be active anywhere. I think going to the mall and going for a walk can be helpful if you're not able to go outside. There's lots of exercises you can do inside your home, videos, or stationary bike or an elliptical. I don't think necessarily you need to move.
Okay. And then we have a comment here. It says, "Hi, I'm a patient of myopathy the last 10 years. While walking, I usually fell down. So what exercises would be good if they're having issues with falling?
So really try not to fall. That's a big problem, is trying to be a little bit safer when you're walking. So using assistive devices if you need to, using AFOs, walkers, holding onto furniture around your home. Really try not to fall is the goal. If you are falling, I would work a little bit more on seated exercises to help maintain your strength that you have now. Doing more isometric exercises or light resistance bands. But I wouldn't do a whole lot of standing exercises if you're already falling and standing, because I wouldn't want to put you at a higher risk for falling. If you do standing exercises, maybe in the water in the pool would be a great place. So you have the resistance of the water that you're moving through, but the buoyancy of the water will help take some of the weight off.
Right. Any other questions from the audience? I'm just looking to see if any come in here.
Sure.
And I think as we wait to see if anyone else has any questions, I also had a commentary on the, you mentioned about using the walker. You know, for a while I was somewhat hesitant on using the walker. I was just using my cane. And what you mentioned exactly was the challenge, right? Because of our gait, it gets, you know, kind of awkward and causes more hip pain. Where as soon as I finally listened to my physical therapist and changed to the walker, I did notice a big difference in the lower back pain and the hip pain. It really was relieved. So just kind of an encouragement to my fellow patients that if you're hesitant on using a walker, especially if your gait is getting a little bit uneven and you're getting more hazard prone to fall, I definitely would recommend the walker. It just makes you feel better at the end of the day, and you feel a lot more comfortable with not feeling like you're going to fall or you lose your balance, because it's so much easier just to grab onto that walker if you do feel like you're going to lose your balance.
Oh, that's great. I'm glad to hear it helped you.
Yeah.
But it is hard to make that shift.
It is, yeah. Okay, so I did get another question here. I'm a patient for over 15 years and started using BFR, blood flow restriction therapy, for a couple of years now. I feel that it's helping me maintain my strength. Have you heard of this, and would you have any insight?
I have heard of it, and that is a big new topic within just the whole neuromuscular disease population. It does seem to be helping maintain strength for a little bit longer, but you're right. It is a little bit, can be uncomfortable because you are restricting blood flow to that muscle and then asking that muscle to perform under the blood flow restriction. I feel like most clinics are kind of moving into that direction. So I feel like if it's helpful, why not continue to do it? I don't really see any contraindications at this time, not that I know of, but if it helps you, I'm all for it. Keep doing it.
Awesome. All right, another question came in. What are some exercises we can do in the pool?
Oh, so lots of exercises. You can do standing, like hip, moving your leg out to the side and back, forward and back, heel raises, squats, even just walking across the pool and back, depending on how much strength you have, either in like waist high water. Sometimes you'll need chest high water just to move across the pool. It's a great way to strengthen because you're moving against, or to maintain your strength because you're moving against the resistance of the water, but it also provides buoyancy. So it helps keep you afloat and helps take some of the weight off of the moving limbs. So sometimes people will do balance exercises, just standing on one leg, doing heel raises, squats, anything you can think of. Anything on land that you feel like you're having a hard time with, you can do in the water, and it should be a little bit easier.
Okay. Another question we got was, please recommend any back strength and leg strength therapy?
Back, so usually it's hips is what it comes down to. Most patients have back pain because of their hip weakness. So really strengthening hip extensors, hip abductors. So doing a lot, if you can, do like partial sit to stands, partial squats, bridging on your back where you're lying down and lifting your bottom. Those are great exercises, or sitting, and you can put a band or just use some resistance to open and close the legs. Pushing open to really work on hip abductor strength can help with back pain. And sorry, what was the other one? Back pain and?
Leg strength.
Leg strength, yeah. So I would work on hips. Anything you do to strengthen your hip abductors and extensors will help with your lower back pain.
Okay. Let's see, another one is physiotherapy good for patients of myopathy, and which diet is necessary we must take? That's a question.
So I would say definitely coming to physical therapy to get you started on an exercise program, to trying to find something that fits you and fits your needs. But trying to find a therapist that understands GNE myopathy can be difficult. So I would say go to like a neuro specialist. Usually they'll have better insight, and if they don't, hopefully they'll reach out and research some things about GNE myopathy. But just making sure, right, you're not over fatiguing, you're not having any muscle soreness or pain. Some of the things that I talked about during this lecture are the big contraindications for exercise programs. But I would definitely start on one. Just come see somebody who can help you, give you some guidance onto where to start.
Great. The next question is, are there any safe supplements that would help with muscle fatigue, for example, creatine, while doing therapy, or BCAA afterwards?
Oh, I haven't, nothing has really been clinically proven to help with muscle soreness. Yeah, so I don't know of any special diets or special supplements. There's nothing really proven to help. Sometimes stretching afterwards can help reduce muscle soreness. Making sure you're staying hydrated while you're exercising and after can help prevent like some muscle cramping type of symptoms, but I don't know a great diet that has really made a difference. I know, sorry, I'm not much help.
That's okay, appreciate it. I think those are all the questions that we have, unless I see any pop up here in the next few minutes. A lot of great questions, so appreciate everybody's input from the audience here. We had a lot of good questions coming in. I think as we wait to see if there's any, just give a few more minutes to see if anyone else has any more questions. They might be typing. I did want to remind everybody that we will have another speaker series next Friday at 9 a.m. Pacific, so same time as today. And Dr. Paul Martin will be presenting. So if you're able to join us for that, that would be wonderful. But yeah, that looks like that is all we have for today. So again, really appreciate your time today, Denise.
Thank you. Thank you for having me.
And it looks like, wait, did I have yeah, okay. I thought I had someone raise their hand, but I don't see it anymore. So I think we should be good. Okay. All right. Well, thank you very much. You guys take care.